Good morning, class. I can see we are now around 24. So we can start. The others will join us. I hope you are fine this morning. The others will join us as we move along. Last time, we were able to look at the oxycams, where we looked at the enolics, where we looked at the oxycams and the 3,5-parazolidine where, of course, we had relevant examples, piroxicam, we had phenylbutazone, and so on. And we were able to mention the SAR. We were able especially to highlight the fact that most these enolics are able to undergo ketoinositol and therefore give us an acidic center. And we do require that acidic center usually negatively charged to bind with the cationic site within the COX enzyme, to bind with the cationic site within the COX enzyme. We are sure we do have a carboxylic group, which is to give us the carboxylic ion. And we have stressed that that group is necessary for activity. And therefore, we would expect to have a corresponding area within the enzyme, which will bind the anionic site within arachidonic acid ionically or electrostatically. And that area is what we said, the arginine amino acid, or the guanidino moiety, which comes about because of arginine. So we did mention all those facts, and we were done, and we moved on to the coxibs. We moved on to the coxibs, and definitely I highlighted the fact that the COX are selective COX-2 inhibitors. Please note, they are selective COX-2 inhibitors. They go for the COX-2 enzyme, and it is of high importance or high relevance that they go for the COX-2 enzyme, because we had mentioned that the COX-2 is usually the inducible. We did mention we do have a bit of COX-2, which is also, but most of COX-2 is inducible, and it is induced when you have an issue, when you have an inflammation, when you have an injury, or when you have other stimuli that brings about the release or the formation of the arachidonic acid, or the formation of the prostaglandins. So we did mention, therefore, if you go for the inducible COX-2, then that COX-2 is the one, inducible COX-2 is the one which is responsible for the prostaglandins that are responsible for pain, fever, and inflammation. When you go for the COX-1, and therefore the inducible COX-1, and therefore the necessary prostaglandins will still be synthesized. And once you synthesize the necessary prostaglandins, it means you will have lesser toxicity. All this we have looked at. And we did mention also, for you to be able to go for COX-2, the COX-2 enzyme, you must have some structural differences, or you must go for COX-2 and not COX-1. And we did mention we are able to synthesize such drugs, or such drugs have been synthesized because of the structural differences between COX-2 and COX-1. COX-1 has isoleucine, COX-2 has valine, and because valine is smaller than isoleucine in terms of the steric hydrons, then you find that you can make a drug that has a rigid structure, slightly bulkier drug with a rigid structure, which for the pocket within the COX-2. And that is how the COX-2 selective inhibitors were developed, by looking at the structure of COX-2, the inducible COX-2, noting the differences between COX-2 and COX-1, and going for that difference, synthesizing a drug that goes for that pocket, and therefore selectivity. So that is, I think, where we had gone to, and we were looking at the structure. And as we looked at the structure of the COX-2 inhibitors, there were things that we did mention. Yes, there are still some structural similarities in terms of, you can see you have those two hydrophobic areas. The drug is bulky just like the others. It has those two hydrophobic areas. And all we are saying is that this drug goes specifically for the COX-2. And I think we were able to look at the general SAR. We did mention the general SAR. We talked about that rigid structure. It's either a sulfoamyl group or a group. It's either a group, it's a sulfoamyl group, or a methoxysulfone group or methoxysulfone group or a sulfonamide group. These groups are rigid and therefore they go straight. They do not change in their position. They are rigid. Methyl sulfone, either a methyl sulfone group or sulfonamide group, and they go for that pocket that is within this COX-IB or the selective COX-2 the pocket. Sorry, not the pocket that is within the COX-2 enzyme. We did also mention that these oxidation state of the important that we did mention, and that is why all these groups are actually fully oxidized. We also did mention, if you look at that structure, you have the two phenyl rings. Like if you look at most of the drugs, like if you look at celecoxib, you look at rofecoxib, you have the phenyl rings which are attached to a central ring, the 5-membered ring. And we say that 5-membered ring can be changed to different rings. It can be a furan, it can be a thiazole ring, and it can also be a 6-membered ring. It can be a pyrite ring with retention of activity. So we did mention that there is flexibility in terms of the ring that you have with retention of activity. And indeed, if you look at the structures of the various COX-IBs, you will find that that ring is different. So there is no specific ring or 5-membered ring that you must have. They can be different. You can even have a 6-membered phenyl ring. You can actually have even a phenyl ring or benzene ring. You can even have a pyridine ring with retention of activity. And of course, we have already mentioned that those structural modifications are they are specifically going for the structural difference between COX-1 and COX-2. So we now look at the celecoxib as one of our examples. Kindly look at the structure of that. I think it's on page 17. If you look at that, you can see that celecoxib, you can see all of them end with the coxib, as I said earlier, meaning when you find that the suffix end with the same name, it means those drugs have some structural resemblance or they have the same mechanism of action. It shows that they do have some similarities somewhere. So we are talking about, if you look at celecoxib, for instance, we are talking about those two aromatic rings. So we are saying two appropriately substituted. Why we are saying appropriately substituted is mainly because of that rigid structure, the sulfamol group. It must be appropriately substituted. By appropriate must also means it must be in the right position. It must be in para position, not in any other position. It must be the right group. So that is what we are meaning by appropriately substituted. Aromatic rings must reside on adjacent positions. If you look at our central ring, which we are calling the pyrazole ring, and look at all of them, look at all the various structures we have, you find that these appropriately aromatic rings are adjacent each other during that statement around or about the central ring, and we are considering our central ring to be the 5-membered ring in this drug. So about the central ring for adequate COX-2 inhibition or for adequate selective COX-2 inhibition. Various modifications can be made to the 1,5. We are calling it 1,5 because if you consider that where the sulfamol phenyl group is attaching on that nitrogen you give it position 1, then you go clockwise 2, 3, 4, 5. So that's why we are calling them 1,5-di-aryl pyrazole moiety to deduce the structure activity relationship of that. So what we are saying is that these phenyl rings are attached at position 1,5, and you can have various changes. Just 1 minute. Sorry about that interruption. So we are saying a parasulfamoyl, sulfamoyl phenyl at position 1 of the pyrazole was found to have the maximum potency for COX-2 selective inhibition than a para-methoxyphenyl. So we are comparing the methoxyphenyl because the methox is a simple group, but the methoxyphenyl did not have enough activity, and that is why a sulfamoyl phenyl group, even the sulfamoyl phenyl group, was actually more preferable than the methyl sulfone, and hence in celecoxib you have the sulfamoyl phenyl, which is necessary for optimum COX-2 selective inhibition. We are only saying for celecoxib, that was a group that was found. Remember, this is being done. These are clinical trials which are being done. You test the molecule for maximum activity for you to make sure you deduce or you get the best structure which is responsible for maximum activity. So the pyrazole group, the group which was found to have maximum activity is the sulfamoyl phenyl group. Then if you look at position 3 of your pyrazole, 1, 2, 3, kindly look at your structure, you will see that at that position, so there is a trifluoromethyl group there, and it was again discovered that at that position you could have trifluoromethyl group or difluoromethyl group. Either of them, either the difluoro or the trifluoro, either of them was responsible for maximum again potency. So in addition to the sulfamoyl group, a trifluoromethyl group at position number 3 was also found, or trifluoro or dimethyl was found to have maximum activity, but for celecoxib they chose the trifluoromethyl group, and that resulted in good activity. So when we look at that structure, we are therefore saying you have a 4-sulfamoyl phenyl on one pyrazole as a 1-pyrazole substituent, which is required for COX-2 inhibition. The 4-sulfamoyl, we are just the 4-sulfamoyl, again counting from the substitution, from the position where it is where this ring, the phenyl ring, is attached to the pyrazole ring. You call that position 1, 2, 3, 4. So of course this time it will be 4' because that's a different ring. So the 4', because it's at the position 4', is required. That group we know, the sulfamoyl group, is required for COX-2 selective inhibition. Then the other substituents, as we have said again, the 4-methyl on the 5-pyrazole system has low steric hydrons to maximize potency. Again, if you look at 4-methyl on, or if you look at again on your again, there is a second ring. Again, if you look at where it joins the pyrazole ring, there's 1, 2, 3. Again, there again, we could call that double prime because we have to be able to number, although I'm not putting them here. When you number, because you need to know those positions, you can give them the original ring, the central ring, which is a pyrazole, we can give it the numbering without the prime. The one carrying the sulfamoyl group, we can call it the 1', and the other one prime. So we can therefore mention at the 4' of the pyrazole ring, we have a trifluoro, and the 4' of the phenyl ring, we found to have minimal steric hydrons and therefore resulted in maximum activity. The 3-trifluoromethyl group provides superior selectivity and potency. So the trifluoromethyl group, not only did it bring in potency, the COX-2 enzyme. So that is the, yeah. Oh, you can't even stay with this other one. Umeapea hiyo 202. So those groups that are found to be responsible for maximum or optimum activity. When we talk about optimum, we are looking at what the toxicity, good active COX-2 inhibitory activity with minimal toxicity. So that is celecoxib. We are able to explain the various groups. They are in the specific positions for specific activity. Sorry, again, there was a small problem, but I think it's sorted out. So we are looking at celecoxib. It was the first non-steroidal anti-inflammatory to be marketed as a selective COX-2. In other words, in this class, celecoxib is a prototype. It is well absorbed from the GIT. Peak plasma levels in the OD may be increased, but dosage adjustments in elderly patients generally are not required unless the patient weighs less than 50. So it is well accepted even in the elderly. It is excreted in the urine and feces primarily as the inactive metabolite, is less than that excreted and changed. Metabolism occurs primarily catalyzed by the cytochrome 2C9. Again, when you see drugs that are catalyzed by the cytochrome P450 enzymes, you should remember that there is a chance of a lot of drug interaction. You give them concomitantly with other drugs that are metabolized by the same enzymes or other drugs that inhibit the metabolizing enzyme, then you do expect that you can have drug interactions. Whenever you see, whenever you note that drugs are being metabolized by the microsomal cytochrome P450 enzymes, there is usually room for drug interaction. Again, if you look at this drug, we have said there is a paramethyl group, and you know alkyl groups attached to phenyl rings are highly metabolized. We have discussed that earlier. That group will be metabolized to the alcohol, and then of course to the carboxylic acid, and then that carboxylic acid can undergo glucuronic conjugation. So I think that is something not very difficult. We are saying we do have this methyl group here, highly susceptible. Remember when we were looking at tometin, it had the same group, and we say because of that group, it has very short duration of action. So that group can be metabolized into the alcohol, which can be metabolized the carboxylic acid and can undergo glucuronic conjugation. Why you might require also for us to go up to the glucuronic conjugation is because of these huge groups. The two phenyl rings give these drugs high lipid solubility, and therefore you will have some of it excreted as the carboxylic acid, but you could have also some of it excreted as the glucuronic conjugate. But as we are saying, it is important for us to note that the drug has very high lipid solubility. Even the trifluoromethane also increases its lipid solubility, and therefore it will require to undergo metabolism, very simple metabolism through oxidative hydroxylation of the paramethyl group. Carboxylic, that's just what we have said. The carboxylic acid is conjugated to a slight extent with glucuronic acid to form the corresponding glucuronide. None of the isolated metabolites have been found to have any activity. One of the important things you can notice that it also inhibits cytochrome 2D6. Cytochrome 2D6 is an important drug that is used, that catalyzes the metabolism of several drugs, including the antipsychotics, which we look at in due course, the tricyclic antidepressant, the selective serotonin reuptake inhibitors, also antidepressants. So you find that these drugs are metabolized by cytochrome 2D6, and therefore, if this drug, as I had said earlier, inhibits that enzyme, you will have a lot of drug. You'll have a lot of drug interactions, and that is why sometimes, although the clinicians might not understand this, it's important that you always tell, or the patient always gives a good history and states the drugs they are taking, because you might prescribe another drug that brings a lot of chaos because of drug interaction. It does not appear to inhibit cytochrome isoforms such as cytochrome 2C19 and cytochrome 3A4. These are also other isoforms. You know, when you look at the cytochrome P450, it has many isoforms, and the isoforms either differ in the number of amino acids or the sequence of amino acids. And when these different enzymes differ in the number of amino acid, the sequence of amino acid, they are completely different enzymes, although we call them isoforms. And their choice, their selectivity in terms of the precursor, or in terms of the in terms of the substrate, their choice in terms of the substrate they metabolize, the rate at which they metabolize the different substrate is dependent on the composition, or the sequence of the amino acids. And therefore you will find that a certain enzyme, a certain isoform goes for a specific drug, and this is because of the fact that they are slightly different in their composition. Other drug interaction related to the metabolic profile of celecoxib have been noted, particularly with other drugs that inhibit the cytochrome 2C. Also, this, so they are only saying, you might not remember all the specifics, but all we are saying is that we do expect that there can be drug-drug interaction with of celecoxib with other drugs that are metabolized by the cytochrome P450 enzymes, because there can be inhibition, there can be induction, and there can be competition for the same metabolizing enzyme. So that is very important for us to note. For example, co-administration of celecoxib with fluconazole, very, very important antifungal agent. The fluconazole can significantly increase plasma concentration of celecoxib because fluconazole inhibits cytochrome 2C9. Obviously, so that's what I was saying, that this, you can, when you give with other drugs, the other drug can either inhibit a metabolizing enzyme, it can induce a metabolizing enzyme, it can compete for that enzyme. And because of all those different things, then you will have drug-drug interactions. And no wonder it is very important to know which drugs you are giving together, because if one drug has an influence on the metabolism of the other, then you can do dose adjustment so that you avoid toxicity. So that is very important, especially for us pharmacists, to know how are these drugs relating with each other. In terms of metabolism, are they having what we call metabolic drug-drug interaction? Unlike aspirin, celecoxib does not exhibit antiplatelet activity. Can you tell me what you understand by antiplatelet activity quickly? I don't know why this thing keeps popping up. What do you understand by aspirin bringing about antiplatelet activity? What do you understand by antiplatelet activity? What do you understand by antiplatelet activity? Quickly, class. What do you understand by antiplatelet activity? Can you move quickly, please? That is correct. Inhibits platelet aggregation. Which enzyme are we talking about? Because now you need to be able to understand, to go up to there. Which, yes, it does that. Which enzyme? Which enzyme are we referring to here? Which enzyme does aspirin inhibit to a higher extent than the other? Blocks the formation thromboxane synthetase. So if the enzyme is, answer the question is asked. When you tell me thromboxane, that is not an enzyme. The enzyme is thromboxane synthetase. It's not COX-1. COX-1, remember, it is for COX-1 is for formation of the prostaglandins. And once then, after you have formed prostaglandin G2 is converted to the various things by specific enzymes. So the COX-1 is the first enzyme you can encounter for the conversion of arachidonic acid, for the cyclization and oxidation to give us the prostaglandin. The prostaglandin, which is a precursor, which is the prostaglandin G2. Once you get the G2, remember, then the G2 is converted to the various compounds. It's converted to the prostaglandins themselves. It's converted to the prostacyclins by prostacyclin synthetase. It is converted to the thromboxanes by the thromboxane synthetase. And we did mention the thromboxanes are responsible for vasoconstriction and platelet aggregation. The prostacyclins are responsible for inhibition of platelet aggregation and vasodilatation. And we did mention that in the body, there must be a balance of those two. So if you give a drug that blocks or inhibits the thromboxane synthetase more than the prostacyclin synthetase, then you will have bleeding, and you can be able to use that drug as an anticoagulant. And that's why we use aspirin at low doses as an anticoagulant, because it binds the thromboxane synthetase more than the prostacyclin synthetase. Now, on the contrary, the coxibs somehow bind the thromboxane. They bind the prostacyclin synthetase more than the thromboxane, and therefore they have been accused, or they are related to CVS or cardiovascular complications, and even sometimes I think death, especially before it was known. They have that issue of blocking or of inhibiting the prostacyclins much more than the thromboxane. So that's why we are saying they will not cause bleeding. They cannot be used as an anticoagulant, because they can actually cause more coagulation than needed. So that's what we are saying, that unlike aspirin, celecoxib does not exhibit antiplatelet activity. Concomitant or co-administration of aspirin may increase the incidence of GIT side effects. Again, that we do understand. Another notable potential drug interaction with celecoxib is its ability, like any other of the non-steroidal anti-inflammatories, to reduce the blood pressure response to angiotensin converting enzyme inhibitors. Again, you will do drugs that are responsible for reducing blood pressure, and one of the compounds that in the body that produces blood pressure is angiotensin, and therefore you have enzymes we call angiotensin converting enzyme. So if you give angiotensin converting enzyme inhibitors, this angiotensin is responsible for vasoconstriction. So if you give angiotensin converting enzyme inhibitors, you will inhibit the formation of angiotensin. Angiotensin is a vasoconstrictor, and therefore you will lower blood pressure. So we are saying they will reduce then if you give celecoxib with like just like other non-steroidal anti-inflammatories with these drugs, then they will decrease their activity. Now again, so the next drug, it should be Rofe, not Refe, Rofe. Second drug, again, we are just trying to demonstrate the various structures. If you look at rofecoxib now, this has a methyl sulfone, that's a methyl group. Methyl sulfone is a that phenyl group, this time not substituted, and this time you have a furanone, because you do have that carbonyl group there. It was a pyrazole. So we did mention, and this is just to demonstrate one of the SARs where we said that the 5-membered ring can be 5-membered rings with retention of various heterocyclic rings with retention of activity. So there we have the furanone and metabolism. You can bond, and this is what we are calling the cis-tubine here. So the cis meaning these groups are the same size. Cis-tubine is just having that
Meet the innovators shaping tomorrow. A horticulturalist paints his passion and redefines our relationship with food. As soon as you put some seeds in,
plasm, we call them systolic enzymes, to either the cis and trans dihydroderivatives. Also isolated is the glucuronide of hydroxyl derivative that is also from, again, the cytochrome 2C9 oxidative metabolism. None of the isolated metabolites of pharmacological activity for either COX-1 or COX-2. So we are only saying here there is 2 oxidative hydroxylation of the furanone ring, but you can also not of the furanone ring, but you can also have reduction, as we have said, of the double bond within the stubin, with, of course, loss of COX-2 selective, with loss of the selective inhibition of the COX-2 enzyme. Again, all these drugs, just like the others we have talked about, they are for pain, fever, and inflammation. Of course, with the higher slight advantage that we are saying these drugs will cause lesser toxicity in terms of GIT, in terms of the kidneys, but we have said there is an introduction of another, and there is a newer cardiovascular complications. Then valdecoxib, again, soluble in alkaline aqueous solution, protein binding for all of them is usually high. It is extensively metabolized. So the primary metabolite for valdecoxib involved, again, I think I have those structures that I had given you, those structures. So please look for them so that you can appreciate the difference in these structures. There's even valdecoxib is there, and the valdecoxib has the methyl. Valdecoxib still has the sulfamyl group. So the primary metabolite for valdecoxib, again, cytochrome P450 enzyme, giving us what we have talked about, the issues of drug interactions, where you have the 5-methyl group, which was further metabolized to the inactive carboxylate. So the same, very similar to the metabolism which is found in celecoxib. You have that methyl group which is found, but the methyl group this time is found in the oxazole ring. You can see here we have the isoxazole ring, isoxazole ring. So the methyl group is part of the isoxazole ring, and that can be readily metabolized to the hydroxyl group or to the alcohol, and then, of course, to the carboxylic group. Oxidative breakdown of the N-hydroxysulfonamide functional group. Also, for this one, somehow the sulfamyl group also did undergo oxidation to the sulfonic acid and sulfonic metabolites, which were also found not to be active. They are also O and glucuronides are the major urinary metabolites. So we are saying that again, that drug, that is the valdecoxib, can undergo, I don't know whether I had its metabolism in here. I don't think I did.